So it's now my pleasure to introduce Dr. John Zugazagoitia from Hospital 12 de Octubre in Madrid, who will be talking about cell therapy, CAR-Ts, and vaccines.
Okay, thank you, Nacho, for the introduction, and thank you, Delvis, and the organizers for the invitation. This meeting is becoming bigger and nicer every year, so very happy to be here. I have to say that the topic for this year is quite challenging, Delvis, but I will try to do my best. So as you know, we don't have that many clinical data for cellular immunotherapy or vaccines for solid tumors. So I will review some of the clinical data that we have, but I will also share with you some of the limitations and unknowns that we have for future development of these treatment strategies. This is my disclosure. This will be the outline, very brief introduction, and then I will speak about adoptive T-cell therapy and vaccines. So basically, I like this idea of trying to classify immunotherapies based on whether they are trying to enhance the immune system, typically to supraphysiological levels, on the hypothesis that this, let's say, superactivation will lead to tumor response, and on the contrary to those immunotherapies that are trying to release immune suppressive factors that are present typically in the tumor microenvironment, being PD-1 axis blockade, as you know, the best example here. And just as a reminder, the talk for today, all of them are immune enhancers, including vaccines and cellular immunotherapy, of course, and by themselves, they are not tackling with blocking immunosuppressive factors in the tumor microenvironment. We have to keep this idea in mind. So adoptive T-cell therapy, and this is a typical cartoon, classical cartoon from this very nice review from 10 years ago already, that is trying to depict the classical adoptive T-cell therapies that we can deliver to patients. And this is as a reminder for the younger people that are here with us, residents and so on. We have these three different modalities, either T-cell therapy, where you have to isolate the tumor, extract the T-cells, expand them ex vivo, and then give them back to the patients. Theoretically, T-cells are not modified in this process. I mean, the T-cells that you give theoretically are the same that the T-cells that were present with the patient, although you will see that there are some changes that happen during this ex vivo expansion, and I will share with you that in a minute. And then you have either the TCR therapies or the CAR T-cell therapies, where you don't have to do the surgical excision of the tumor. You isolate the T-cells from the typical or classical leukapheresis from peripheral blood, but you have to modify them genetically. Either you increase the affinity of the T-cell receptor for an antigen that has to be expressed under MHC class II, or you generate a chimeric antigen receptor that will visualize or will see an antigen that is in the surface of the membrane. It doesn't have to be present under MHC class I conditions. And this is an important difference to take into account. So the adoptive T-cell modality that is more advanced in clinical development, of course, as you know, is T-cell therapy. We do have a randomized phase 3 trial in metastatic melanoma progressing on PD-1 axis blockade, where T-cell therapy is superior in terms of PFS to ipilimumab, and this is unquestionable. Randomized phase 3 trial conducted in the Netherlands, 2 institutions, but these data are unquestionable in terms of efficacy. I think, in my opinion, to this kind of therapies, seeing PFS increment, it's good, but these therapies are quite complex to deliver, so beyond seeing increment in PFS, I think we have to see a real increment if complete responses and perhaps responses with curative potential. Likely we will see them when this trial matures and when we will see new data from other trials that are ongoing, but to the best of my knowledge, we haven't seen that yet, and this is something that we have to recognize. In lung cancer, there are small experiences with T-cell therapy as well. This is the classic study published by the group of Scott and Antonia in Moffitt Cancer Center, single-center study. It showed the feasibility of doing T-cell therapy in refractory patients with non-small cell lung cancer. As you can see there, this was, of course, a relatively small study, but you see the challenges here. 32 patients were assessed for eligibility. In the end, only 15 patients were actually treated with the T-cell therapy and nivolumab in this case. So there is significant loss of patients during this process of T-cell expansion, as you know, and this is a challenge that we have to face with this kind of therapies. And also in this process of patient selection, there is actually patient selection. I mean, there is potential for selection bias. And as you can see, if you look at the patients that were treated in this trial, more than 60% of those patients were patients whose tumors harbored oncogene driver alterations, including very classical driver alterations such as RET fusions, EGFR activating mutations, and so on. And there is activity here, apparently, but it's difficult in a clinical trial like that to separate what is prognosis from true activity from these therapies, because sometimes, as you know, these tumors can have more indolent natural history, and I think it's difficult to really delineate the true activity here. But at least the trial showed that the TIL therapy can be, it's feasible to these patients with lung cancer. But there are several questions that I wanted to share with you. And the first one is this. So we are assuming that the T cells that are in the tumor are all of them educated to see cancer cells and to kill cancer cells, but this might not be the case. Actually, less than 10% of the T cells that populate a tumor are tumor reactive. This is data from Tom Schumacher group, and other groups have also replicated the same thing. So actually, the minority of T cells in a tumor are recognizing tumor antigens. This doesn't mean that the other bystander T cells are not capable to kill cancer cells after expansion, but at least they were not educated by the Mother Nature to kill a cancer cell. And this is something that we have to keep in mind. Also, as I was saying before, during the expansion of the T cells, a lot of things happen. And actually, there is a selection, strikingly, of T cells that are not tumor reactive when you use classical Rosenberg IL-2 expansion protocol. This is data from our group, from the group of Luis Alvarez-Ballina. On the left-hand side, you can see this is a primary tumor from a patient. It's a human cancer. The colors there are reflecting the different clonotypes that are populating a tumor. And the one in red is not highlighted here, but I can tell you that the clonotype in red is not a tumor-reactive clonotype. Actually, this clonotype was seeing an antigen from the Epstein-Barr virus. And you can see that after ex vivo expansion, this clonotype becomes dominant in the final T-cell product. And this will be the product that the patient will receive. So actually, is this potential limiting efficacy? I don't know. But at least this is something that actually happens. And this has been also replicated by different groups. And this is something that we have to consider. And finally, there is another elephant in the room, because there is accumulating evidence, basically from the preclinical literature, saying that T cells in the tumor perhaps are not the ones driving sustained anti-tumor response. And perhaps those that are residing in lymph nodes are actually the ones that are driving sustained response. And there are multiple, actually, papers in the same line showing the same evidence. So maybe we have to revisit this. Maybe sentinel lymph node could have something to do here when preparing the T-cell products. These are some thoughts that I wanted to share with you, but I actually don't know the answer, honestly. And then moving on to the genetically engineered T cells. So first, the TCR modified T cells, as I was explaining before. These T cells have been genetically modified to increase their affinity of the T cell receptor for a given antigen that, again, has to be processed and presented by the MHC class I molecule, meaning that these compounds or these products will not work in those tumors that have lost MHC class I as a mechanism of immunosuppression. You know that many solid tumors do this, particularly, as an example, small cell lung cancer is a typical example that loses MHC class I, so these kind of products wouldn't theoretically work. And this is one of the most recent examples. You know that these therapies have shown data in synovial sarcoma, for example, but I'm showing here some very nice data with this ANSU cell TCR T-cell therapy in uveal melanoma. And this was presented at ESMO last year, showing, to me, very convincing responses. The trial is limited in size, only 15 patients treated, but responses are as high as almost 70% responses. Remember, this is uveal melanoma. And these responses are durable, including 2 patients with responses exceeding 2 years. To me, this is very convincing data, not only to me. Actually, the ESMO committee selected this abstract for the plenary session, and I think it definitely deserves it. And then there are other examples with the same concept, but targeting different antigens, presented again by the MHC class I, KRAS G12B, TCR-T-directed therapy in other solid tumors. In this case, data also presented at ESMO, showing some activity also in pancreatic carcinoma and colorectal carcinoma, tumors that we know typically immunotherapy, or at least PD-1 axis blockade-based immunotherapy doesn't work. And here we are seeing some activity. I think it's still the numbers are small. The trials have to evolve. But, well, the data in uveal melanoma, we can translate them to make them work in a tumor that contains a KRAS G12B. You can imagine the potential implications that this could have for patients with different solid tumors, including, of course, lung cancer. And then, finally, the CAR T cells. As you know, one of the limitations of CAR T cells is that it is difficult to find an antigen in a solid tumor that is expressed specifically by tumor cells and not in normal tissues. But we do have an example where CAR T cells could eventually work, or at least an antigen such as DLL3 that is an appealing antigen for these therapies to work. You know that in normal conditions, DLL3 is localized in the cytoplasm, so theoretically not visible for a CAR T cell. But in transformed neuroendocrine cells, this protein delocalizes to the cell membrane, so it is now visible to the CAR T cells, but only in the tumor, not in the normal tissues. But we have seen data by Yanis, also Luis presented yesterday, where I would say that these results, at least today, are a bit disappointing, at least if we compare them with T-cell engagers, which, by the way, are another modality to redirect T-cells to tumor cells, and they are far more advanced in clinical development. And finally, a few words on vaccines. You know that classic vaccines were using tumor-associated antigens in solid tumors, including lung cancer. Classical antigens used for vaccination were MAGE and NY-ESO, as you know. And 2 conclusions from these trials that were performed. First one is that most actually confirmed that vaccines were working in the sense that they were activating peripheral T cells. I mean, vaccines were doing what they were designed to do. The problem is that this T cell activation was not sufficient to produce an anti-tumor response. Next generation vaccines are trying to resolve some of these limitations, either because you design a vaccine that theoretically is more specific to produce an anti-tumor response because you use neoantigens present in the tumor. And this is data in melanoma, also presented in ESMO, that I think they are quite encouraging in the frontline setting in combination with pembrolizumab. You can see 92% of the responders continue to respond at 2 years, typically numbers that perhaps are lower when you only give pembrolizumab. Also, mRNA vaccines. This is one example of our mRNA vaccine that was designed to induce T-cell responses against cells expressing PD-L1 and IDO1, which you know are proteins that induce immunosuppression. And well, I think there is nice data, I would say, also presented at ESMO, showing that this vaccine, in combination with pembrolizumab, was producing responses, and in line with the mechanism of action of the vaccine, responses occurring preferentially in tumors that were expressing PD-L1. So I would say this is nice data, still limited number of patients, but it's there. And finally, limited data in lung cancers, but interesting trials currently ongoing, such as the Interpath 009 trial that is designed to prove that vaccination with a tumor neoantigen-based vaccine in combination with pembrolizumab will be superior to pembrolizumab alone in those patients with residual cancer cells after neoadjuvant chemoimmunotherapy. So just to conclude, 4 ideas: adoptive T-cell therapy, positive results in melanoma, and I think this actually has to prompt us to have the same idea and concept to move this positive data in other solid tumors. And again, this concept that T-cell engagers also redirect T-cells, and to me, at least, they have shown more convincing data than CAR T-cells. Let's see how the field evolves in the future. And, there are data from large clinical trials with next-generation vaccines that I think we all eagerly await. Thank you very much.